Dr. Davie Wong is an infectious disease consultant at Royal Columbian Hospital and Eagle Ridge Hospital in Fraser Health. He has an office practice in a multidisciplinary clinic in Burnaby called Centrio Medical Specialists. He also provides care for HIV patients at Positive Health Services Clinic in Surrey. He is a member of the Regional Antimicrobial Stewardship Committee. Davie is a clinical assistant professor in the Division of Infectious Disease at UBC. He obtained his medical degree and completed his internal medicine residency at the University of Manitoba before coming to UBC to complete his infectious disease fellowship. And he's going to present to you today. I encourage you to put your questions and comments in the chat, and at the end of the presentation, I'll moderate those and provide your comments and questions to Dr. Wong. So without further ado, Davie, I'll pass it on to you.
All right, thanks, Aaron, for the kind introduction. Just gonna load my slides. Okay, so yeah, thanks for inviting me back. So the topic today is on community-acquired pneumonia, or CAP, with a focus on the outpatient setting. So I've only received a speaker's honorarium for UBSC CME event 2019, and as Aaron mentioned, some of you might remember seeing me in June of this year presenting on skin and soft tissue infections. So this presentation hasn't received any funding, and to mitigate bias, I've provided references where applicable, and there will be some poll questions for you guys to participate. So the objectives of the presentation are to review the diagnosis of pneumonia using evidence-based methods, learn the common pathogens implicated in CAP, how to distinguish between viral and bacterial pneumonia, how to choose the right drug, the right route of administration, and the right duration. I will touch briefly on scoring tools to help you risk stratify your patient to decide on outpatient or inpatient treatment. And then we'll look at some strategies on how to minimize the risk of CAP. And then at the end, I'll conclude by discussing some common indications to refer to a specialist. So as we all know, pneumonia is infection of the lower respiratory tract or lung tissue, and lung inflammation can cause various symptoms and signs like fever, cough, shortness of breath, tachypnea, etc. So the diagnosis of CAP depends on obtaining a proper history, detecting relevant physical exam findings, and demonstrating an infiltrate on imaging, most commonly a chest x-ray or sometimes a CT scan. Many patients don't present in a textbook manner, so often the diagnosis remains unclear. And in the elderly, their main symptoms may include falls, altered mental status, fatigue, lethargy, anorexia, and then less commonly, the classic chest pain, cough, fever, and leukocytosis. So these older patients typically have an inadequate inflammatory response to infection because of a relatively weakened immune system, which then can lead to under detection of pneumonia and underestimation of the severity of infection. So let's throw the first question at the audience then. So you got this previously healthy 35-year-old female smoker, comes in with 5 days of fatigue, productive cough, worsening shortness of breath, fever 38.9 degrees Celsius. She has decreased breath sounds in the right lower lung field. Heart rate's 105. Rest of the vital signs are normal. What is her estimated probability of CAP? So let me just load the poll for you. Okay, I think most people have answered. So most people picked 60%, then 80%, then 30%. Okay, so apparently humans are notoriously bad at estimating probability and predicting risk. So this is an interesting study where they surveyed over 500 clinicians. They were asked to estimate the probability of pneumonia in the clinical scenario I just showed you, and then recalculate the probability if the chest x-ray is positive or negative. So on the far left here, you see that the probability of pneumonia before you got the chest x-ray is estimated to be about 25 to 40% based on the evidence. But almost everyone overestimated the probability, and the vast majority of people thought it was 80% or higher, and some were even confident enough to say they were 100% sure. The middle diagram shows the probability of pneumonia if the chest X-ray is positive. The evidence-based probability is around 45 to 65%. And again, everyone overestimated the probability, and nearly everyone guessed at least 85%. And even more people feeling 100% sure now it's pneumonia. But reality check, there's no such thing as 100% medicine, right? And then on the far right, you have a negative chest X-ray. The evidence-based probability is 10 to 20%. But now you see the responses are more spread out, but most people still overestimated the probability, right? So the bottom line is clinicians overdiagnose and as a result overtreat pneumonia, likely because there's a disconnect between the knowledge and the evidence and the impact of cognitive biases. So we often forget that no test is 100% accurate, and the probability of a patient having a disease depends on the pretest probability and the accuracy of the test itself. So for CAP, if a patient comes to your office with a cough, there's a 5% chance they have pneumonia. So this is the pretest probability. If that same patient comes to the ER with a cough, the pretest probability is now higher at 15%. Now, if you have cough plus one of sputum, fever, or hemoptysis, the chance of having pneumonia is 10%. So it's important to estimate a pretest probability because this will impact the post-test probability later on when you're interpreting the physical exam finding and lab results. So let's look at the evidence behind the physical exam for diagnosing pneumonia. So in a study of more than 6,000 patients, the sensitivity and specificity were derived for specific physical exam findings. So interestingly, the presence of cachexia had some decent power to help rule in pneumonia with a positive likelihood ratio of 4, while having all normal vital signs decreased the probability of pneumonia with a negative likelihood ratio of 0.3. So none of these findings are spectacular, however. And now moving on to the chest exam. So surprisingly, the presence of asymmetric chest expansion is 100% specific for pneumonia in this study, but that's hard to believe because there are many other conditions such as pneumothorax, pleural effusion that can cause asymmetric chest expansion as well. Then you have percussion dullness, bronchial breath sounds, and echophony, which if they are present can actually increase the probability of pneumonia. But the absence of these findings does not rule out pneumonia at all because the sensitivity is way too low. Then there's something called the Heckerling score. It combines 5 independent findings of pneumonia, so fever, tachycardia, crackles, diminished breath sounds, and absence of asthma. So when you have 4 or 5 findings, this greatly increases the probability of pneumonia with a positive likelihood ratio of 8.2. But the absence of all finding decreases the probability of pneumonia with a negative likelihood ratio of 0.3. But its ability to rule out pneumonia is weaker than its ability to rule it in. So now that you know which physical exam findings are useful for diagnosing pneumonia, the next question is, can we actually trust ourselves to detect these findings when they're actually present? So sadly, the answer is no. So clinicians can't seem to agree when the finding is present or not. So on the far right, you've got the kappa value. It's a measure of the level of agreement among clinicians. And unfortunately, most of the physical exam findings have a kappa value of less than 0.5, which means at best, there is a weak level of agreement. So if you auscultate crackles, I might hear wheezes. So who's right, who's wrong? So sometimes the likelihood ratio is a bit difficult to understand. So this is another way to look at it. So if the likelihood ratio, if the positive likelihood ratio is higher, that means it raises the probability of having the disease even more so. So for example, if you have a Heckerling score of 4 or 5, then the probability of pneumonia increases by around 40%. But if you have a very low Heckerling score, it only decreases the probability of pneumonia by maybe 25% because, as I said, its negative likelihood ratio is weaker than its positive likelihood ratio. So the presence or absence of certain findings will either increase or decrease the probability of pneumonia. And of course, the more positive findings you have, then the more confident you are that the patient has pneumonia. So I'm going to illustrate this for you with this example. So let's assume you have this patient who comes to your office with a cough. So like I said, the pretest probability is about 5%. So start with the far left diagram. So if you hear bronchial breath sounds, then the probability of pneumonia is now 17%. That's the blue line. But if you don't hear bronchial breath sounds, that's the red line, the probability remains at 5% because the absence of these chest findings does not have sufficient power to lower the probability of pneumonia. Okay, moving on to the middle diagram. So let's assume you also elicit percussion dullness. So now your probability goes from 17% to 25%. And if you're really a superstar and you auscultate egophony, then the probability goes from 25 to 55%. So you can do this with any number of tests. So let's move on to imaging. A CT scan is considered gold standard for diagnosing pneumonia, but obviously we're not doing CT scans on everyone because of the cost, inconvenience, and radiation exposure. You should, however, order a CT if you're concerned about a lung abscess, empyema, non-resolving pneumonia or recurrent pneumonia, or maybe a lung tumor. So sometimes pneumonia might be the first sign of a lung cancer. The chest x-ray is the tool we rely on the most when diagnosing pneumonia, but it actually performs quite poorly for this indication. So it's only accurate about 2/3 of the time with both viral and bacterial pneumonia. So it either overcalls or undercalls pneumonia in about 1/3 of cases. It cannot reliably differentiate between viral and bacterial infection. And around 21% of the time, the initial chest x-ray might be negative in patients who actually have pneumonia. And then when they looked at the level of agreement between radiologists reading the chest x-ray, this was deemed to be poor or fair. So bottom line is the most important test we rely on to make a diagnosis of pneumonia really sucks. So then when should you even order a chest x-ray? So this goes back to the pretest probability. So if this patient comes to your office with a cough, then the chance of pneumonia is 5%. So let's say you order a chest x-ray, and we'll use a sensitivity of 69% and specificity of 78%. So look at the table on the far right. So the pretest probability is 5%. Then if you have a negative chest x-ray, that drops the post-test probability to 2%. And if the chest x-ray is positive, the chance of having pneumonia is now 14%. So in this case, a negative chest x-ray merely confirms your low suspicion for pneumonia in the first place, and a positive chest x-ray does not have enough power to increase your diagnostic confidence. So I personally would not be treating for pneumonia if the probability is only 14%. And so a chest x-ray is most useful when the pretest probability is somewhere in the middle. So if this patient has cough and some other positive physical exam findings, your pretest probability may be 30%. So in this case, the chest x-ray has greater power in changing the probability. So if the chest x-ray is positive, then you will likely treat for pneumonia as the probability is now 57%. And if it's negative, then you likely shouldn't treat because the risk is only 15%. So now let's say the same patient has all the positive symptoms and signs of pneumonia such that you're 80% confident about your diagnosis. So positive chest x-ray raises the probability to 93%, but a negative chest x-ray does not lower the probability enough for you to omit antibiotic treatment. 61% is too high to not treat for pneumonia. So the chest x-ray performs poorly when the pretest probability is either very high or very low. It performs best when it's in the moderate range, right? So remember, a chest x-ray does not diagnose the pneumonia, it's you who does. All right, so here's an example of patients with pneumonia. On the left here is a classic lobar pneumonia caused by typical bacterial pathogens such as strep pneumo. You can see the consolidation in the right lower lung. On the right side, you see diffuse interstitial pneumonia, which can be caused by atypical bacterial pathogens like mycoplasma, chlamydophila, and viruses. And when I say typical bacteria, this refers to bacteria that are susceptible to beta-lactam antibiotics. They can grow readily on standard culture media in the lab, and they tend to cause a very acute illness with high fever and productive cough. The atypical bacteria do not respond to beta-lactams. They do not readily grow on standard culture media, and they can cause a subacute illness with milder symptoms or even extrapulmonary symptoms. So what about using biomarkers for diagnosing CAP? So in general, ordering biomarkers might be impractical in the ambulatory setting, but there is some evidence for using CRP and procalcitonin in pneumonia. So these might be useful to obtain if you can get the results quickly. For example, if you work in the ER. In the UK, where they actually have point of care CRP testing, their guidelines actually recommend doing a CRP. to help guide clinicians on whether or not they should prescribe antibiotics. So by using a cutoff of 20, antibiotics are discouraged when the result is less than that. The procalcitonin is a marker that rises with bacterial infection. So when the value is less than 0.25, antibiotics are not recommended. And at best, the sensitivity and specificity of procalcitonin for bacterial infection is around 80% each. So I personally don't rely on these biomarkers because I think clinical judgment is more important than any imperfect lab result. So be aware of the limitations if you do order them, right? They only add one piece of extra information to clinical case, and that extra piece of information does not necessarily improve patient care, but might actually make it worse. Okay, moving on to question 2. So what proportion of outpatient CAP diagnoses are considered incorrect? So I think I made a mistake here. Please answer that as what proportion of outpatient CAP diagnoses are considered correct? Okay, so most of you have answered. So we'll end the poll. So 76% of you chose 40 to 50%, followed by 50 to 60%. Okay, so these numbers are quite depressing. So pneumonia is actually very difficult to diagnose. These numbers represent cases that were overdiagnosed as pneumonia. So in the outpatient setting, 34% of patients labeled with CAP did not actually have CAP. All right, so depending on where you're practicing, the misdiagnosis rate for inpatients range from 11 to 17% in the US, up to 37 or 38% in the UK or Malaysia. And the common mimickers of CAP are CHF, upper respiratory tract infections, or COPD exacerbation. All right, next question. What is the most common pathogen implicated in CAP? So most people pick strep pneumo, 52%, followed by viruses, 39%. So both are kind of correct, actually. So in the pre-antibiotic era, strep pneumo was the cause of 95% of pneumonia cases. So nowadays, viruses appear to be overtaking bacteria as the most common causes of CAP. Fungal and mycobacterial pathogens can also cause CAP, but I'm not going to focus on these rare pathogens that often require specialist input. So outpatient CAP is usually treated empirically because it's impractical and not worthwhile to try to identify the pathogen. So microbiology testing is controversial, and the results have little to no impact on antibiotic management because most patients get better anyway with empiric antibiotics. Though this approach has its own drawbacks because if you're not sending cultures from low-risk patients and only obtaining cultures from people who are failing treatment or high-risk patients, then the local antibiogram data is biased towards high-risk patients, and then the susceptibility data does not accurately capture the resistance profile in the whole community. So let's say you get a positive respiratory tract sample. It's actually tricky to interpret because the microorganism can be present because of colonization as part of normal flora, or because there's actually an infection. So we now know that the lungs are not actually sterile and a lung microbiome does exist. So remember, a positive microbiology does not diagnose the infection. It's the clinician interpreting the results. So be careful not to overdiagnose patients simply because of a positive culture result. So here's some data from the United States. So over half the time, a pathogen is not identified, perhaps because no culture was taken, the sample was inadequate, perhaps early antibiotic exposure may have decreased the yield of the culture, or simply that our current diagnostic testing has limitations. But when a pathogen is identified, you see that it's commonly a virus at 21 or 22%. Bacterial pathogens are identified only 11% of the time. And with the widespread use of pneumococcal vaccines and decrease in smoking rates, the incidence of pneumococcal vaccine is declining. It's important to remember, though, that when the viruses are picked up from an NP swab, and if that result is positive, it only means that viral DNA is present. And so it does not prove that the lower respiratory tract infection is actually caused by that virus. And you don't know if this virus had actually predisposed the patient to a secondary bacterial infection. So therefore, the positive viral PCR does not prove causation and does not exclude a bacterial pneumonia. right? So this is the limitation of the NP swab. And almost 20% of patients who have a proven bacterial pneumonia are actually co-infected with a virus. So in Europe, where pneumococcal vaccine uptake is lower and smoking rates remain high, strep pneumo remains the dominant pathogen. Viruses make up only 7%. And again, vast majority of cases, 60%, they have no identifiable pathogen. So this is the only microbiological data I could find for Canada. It's pretty old, from 2005, so it might not be applicable now. So pathogen was identified by sputum culture, blood culture, serology in about half of patients. So interestingly, Mycoplasma pneumoniae and Chlamydophila pneumoniae were the most common pathogens detected at 15 and 12%. And the strep pneumo came in at third place at 6%. But the serology was used to diagnose chlamydia or Chlamydophila and Mycoplasma, and one of the limitations of that is it might actually overcall the true infection rate. And also, they did not test for viruses, which we now recognize as common agents in CAP. So now that viruses are dominating the CAP arena, how do you differentiate between viruses and bacteria? So although some features do overlap, these are some clues to help you out. So viral infections tend to develop gradually, while bacterial pneumonia is more acute in nature. So viral infections affect multiple mucosal membranes. So you might have upper respiratory tract infections, rhinorrhea, pharyngitis, or otitis media. And with bacterial pneumonia, you often get high fever, headache, and interestingly, painful cervical lymph nodes. And on chest exam or imaging, viral infections can be bilateral, while bacterial are generally unilateral. And to make things even more confusing, not all bacterial or viral pneumonias behave the same way. So a typical bacterial infection caused by strep pneumo can present very acutely, sometimes in septic shock with dense lobar consolidation and leukocytosis. Legionella pneumonia presents similarly, but it can also have extrapulmonary manifestations such as confusion, diarrhea, hyponatremia, and elevated liver enzymes. So you should think about Legionella in patients who smoke, have COPD, are immune compromised, they've traveled, or are exposed to cooling towers or whirlpool spas. Atypical bacterial pneumonia caused by Chlamydophila and Mycoplasma tend to affect younger people with little to no comorbidities. So it's generally less severe and it rarely leads to acute deterioration. The symptoms are low-grade fever, dry cough, and possible upper respiratory tract symptoms such as pharyngitis. Inflammatory markers might be normal or mildly elevated. And then vast majority of cases are mild and they're often self-limited. So antibiotics are kind of controversial in this area. So it's not mandatory you treat these. Sadly, though, the differentiation between typical and atypical pneumonia based on history and chest imaging is often unreliable. So let's say if it's a viral infection, how do you know if it's influenza or a non-influenza? So there are some patients who might viral treatment if it is influenza. So often there's no time to test and wait for a result before treating. So generally people with influenza have acute onset of symptoms, systemic symptoms such as fever, chills, myalgias. Sore throat and runny nose are more likely with non-influenza viral infections. So now that you've diagnosed someone with CAP, how do you determine if they need to be admitted to hospital? So the two most commonly used scoring tools are CURB-65, which was created by the British Thoracic Society, and the Pneumonia Severity Index, or PSI, which was developed in the United States. So none of these scoring tools can fully capture all the medical or psychosocial comorbidities that impact recovery, and there may be other reasons to admit a patient to hospital, such as lack of social support, even if the criteria are not fully satisfied. The CURB-65 is attractive because it's easy to use. You get 1 point for confusion, urea more than 7, respiratory rate more than 30, blood pressure less than 90 on 60, and age greater than or equal to 65. The mortality rate goes up as the score increases. So for example, with a score of 0, your 30-day mortality is 0.7%. and then it's 2.1% for a score of 1, and then 9.2% for a score of 2, and 2 is the threshold at which you should consider admitting the patient to hospital. So this score is problematic in the office setting because you don't have blood work readily available for the serum urea level. So that's why they condense the curve 65 to a CRB 65 and eliminate the urea component completely. So as you can see now, the 30-day mortality changes a bit. There's a 1.2% chance of death with a score of 0. Previously, it was 0.7% with the irregular curve 65. And there's an 8.2% chance of death if the score is 1 or 2. So therefore, you can consider hospital admission with a score as low as 1. The PSI includes 20 risk factors in the calculation. It includes age, comorbidities, physical exam findings, and lab results. So it's less convenient to use in the office setting, but it might be helpful in the ER. And it risk stratifies patients into 5 classes. So the higher the class, the higher the mortality. Outpatient management is reasonable for a risk class 1 or 2 because 30-day mortality is low at less than 1%. You should consider admitting the patient to hospital for class 4 and 5 because mortality is quite higher at 8 and 29% respectively. And then for class 3, mortality is around 3%. So you could go either way. You can treat as an outpatient with close follow-up, or you can admit to hospital. So PSI gives a lot of weight to age and comorbidities such that the severity of illness might be underestimated in a young, healthy person. Okay, so next question. What is the most appropriate empiric antimicrobial for treatment of outpatient CAP? So 2/3 of you picked amoxicillin, which is generally the correct answer. So the best choice really depends on many factors, such as local epidemiology of the CAP, pathogen resistance profile, patient factors. So before you decide on a treatment option, determine if the patient falls into the low risk or high risk group. And by high risk, I mean high risk of harboring drug-resistant pathogens or high risk of having a bad outcome with their pneumonia if they are improperly treated. So all the conditions that make the patient high risk are not surprising because they all reduce the capacity to fight infection and increase the risk of drug resistance. And previous hospitalization in the last 90 days is another risk factor for drug resistance. And low-risk patients don't have any of these high-risk features. So I've summarized as many BC guidelines that I could find from the different health authorities, in addition to Bugs and Drugs, which is Canadian, IDSA, which is American, and NICE guidelines, which are British. So you can see there is universal line for low-risk patients. There are some differences in recommendations for second-line treatment, cefuroxime, doxycycline, or macrolide. And for those with a beta-lactam allergy, doxycycline is a common recommendation. And as you can see, no guideline recommends routine coverage of atypical bacteria. So now we start to see some disagreement with high-risk patients. The point of contention is whether or not you need enhanced coverage for gram-negatives and atypical pathogens. I've highlighted the changes from the previous slide in red. And some of the guidelines don't differentiate between high and low risk patients and still recommend amoxicillin as first line. Other guidelines suggest the addition of either doxycycline or azithromycin for atypical coverage on top of amoxicillin. VCH broadens the treatment to amoxiclav. Northern Health Authority and IDSA broaden therapy to amoxiclav and add atypical coverage. So I know it's very confusing. I would just follow your local guidelines. So here's the latest Life Labs Antibiogram data for community respiratory pathogens. So look at strep pneumo at the bottom. It remains highly susceptible to amoxicillin at over 95% and is fully susceptible to levofloxacin at 100%. You could presume that also applies to moxifloxacin. The tetracycline susceptibility is only 71%. But we know that some tetracycline-resistant organisms are susceptible to doxycycline. We just don't know the exact numbers. Macrolides like azithromycin are even less effective at 56%. And if you want to cover for Haemophilus influenza or Moraxella, which are more likely in patients with COPD, then amoxiclav or cefuroxime will get the job done. So this is my own personal summary for outpatient CAP treatment. Most of it agrees with the previous guidelines. So first line is amoxicillin for low risk patients. I think there's universal agreement for that. I use amoxiclav for high-risk patients because they are more likely to have worse outcomes if the initial treatment is suboptimal. And for penicillin allergic patients, cefuroxime would be a good choice. There's no cross-reactivity. And if for some reason you can't use a beta-lactam, then a respiratory quinolone like levofloxacin or moxifloxacin is reasonable. I would only add atypical coverage if there is some suspicion for atypical bacteria. And so remember, the quinolones already have atypical coverage, so you don't need to add a second agent on top of that. And the rationale for this summary is that I place high value on optimal coverage for strep pneumo. There's a strong preference for beta-lactams over quinolones to keep the antibacterial spectrum narrow and to minimize the risk of side effects. I know some guidelines still recommend doxycycline or macrolides. That really depends on your resistance profile. But in the lower mainland, it appears that tetracycline and macrolide resistance is too high to rely on these drugs empirically. So let's say your patient can't take pills because of nausea or vomiting or some dysphagia. So then it would be reasonable to give IV antibiotic that can be administered in the outpatient setting in the hospital. So once a day drug such as ceftriaxone is preferred and most practical. Azithromycin can be added if you're concerned for atypical bacteria. And if the patient's allergic to ceftriaxone, then either levofloxacin or moxifloxacin would be reasonable. So now, does it matter what antibiotic class you choose if the pathogen is susceptible to every drug? So the simple answer is no. So there's no particular drug class that has been shown to be superior to the other one as long as you're covering the right pathogen. And it doesn't seem to matter if you routinely add atypical coverage versus not adding it. So my general rule of thumb is use the most effective, safest, cheapest drug with the narrow spectrum of activity. But in practice, only about 30% of antibiotic prescriptions for CAP are considered guideline appropriate. So the most common reason that the prescription is inappropriate is the wrong drug is chosen 3/4 of the time. The second most common reason, at almost 40%, is the wrong duration was chosen, almost always due to excessive duration. Inappropriate dose was the less common problem. And these numbers add up to more than 100% because you could have the wrong drug and the wrong duration prescribed at the same time. What is the recommended duration for treatment of uncomplicated CAP? So 62% of you chose 5 days, 23% 7 days, and a small proportion 3 days. Okay. So duration is always difficult to get right because each patient is different. So for a long time, the magic number seems to be 5 days for uncomplicated CAP. So as long as the patient has been afebrile for 48 hours and there's no more than one CAP associated sign of clinical instability, and at least 5 days of treatment has been completed, then you can stop antibiotics. So this recommendation was supported by the results of a recent RCT where patients admitted to hospital, not in the ICU, with CAP were randomized to either 5 or 10 days of treatment. And the vast majority of patients received quinolones, which is now no longer recommended as first line. And they found that 5 days was not inferior to 10 days. All right. And then earlier this year, there was a new RCT that tried to shorten the effective duration even further. So this one compared 3 days versus 8 days of treatment. So again, these are all inpatients, not in the ICU. They were eligible for enrollment if they met the all clinical stability criteria by day 3 of treatment. And then they were randomized to 5 days of placebo, which is the 3-day antibiotic group, or 5 extra days of oral moxiclav, which is the 8-day group. So bottom line, the 3 days of treatment was not inferior to 8 days. And so these results should also be applicable to the outpatient setting. So moving forward, the new shortest effective duration should be 3 days. So there's absolutely no excuse to be overtreating uncomplicated pneumonia anymore. So as with many infections, overtreatment is a common problem in CAPS. So despite what the evidence tells us. So 1/4 of patients are treated for more than 7 days in the outpatient setting. And among inpatients, 2/3 of those were on antibiotics for too long, even though almost 90% of them stabilized quickly enough to be appropriate candidates for 5 days of treatment. So interestingly, much of the excess antibiotic duration comes from the discharge prescription. So it seems that the clock is reset at discharge and patients are given a new course of treatment of 5, 7, or 10 days. So even though there's no benefit to overtreatment, right, it only causes harm. And each excess day of treatment was associated with a 5% increased risk of patient-reported side effects, mostly GI problems and sometimes thrush. So remember, the best treatment is the shortest effective one, not the overkill approach. And so if I do the math correctly, the chance that you are diagnosed correctly with CAP and you receive the right drug for the right duration is a dismal 20%. So if you're the patient, how do you feel about those odds? All right, so let's say you've got a patient on treatment for CAP, but things aren't getting better. So ask yourself these 4 questions before changing the antibiotic. Number 1, do you have the wrong diagnosis? So is there a non-infectious cause like CHF? Is there a drug fever, or is there some other undiagnosed infection? Number 2, are you using the wrong drug or are you underdosing the right drug? Okay, so for example, are you using azithromycin in an area where macrolide resistance is very high? Number 3, are you targeting the wrong pathogen? For example, are you treating a true bacterial pneumonia with oseltamivir, thinking it might be influenza? And finally, number 4, is there a complication of pneumonia? Like a lung abscess, empyema, or some obstructing tumor. So be sure to go through this thought process so you're not missing something critical. So for pneumonia prevention, there are modifiable and non-modifiable risk factors. So the things you can't control are listed on the far right. For the modifiable risk factors, smoking cessation is key because smoking obviously damages the lung and impairs immune defenses. Drinking too much alcohol can weaken the immune system and might lead to increased risk of aspiration events. Animal exposure might not be too relevant unless you have a bird or farm animals. So I wouldn't worry too much about that. Diabetes is a risk factor for many things, and we already emphasized the need for good glycemic control. So pneumonia prevention is just another added incentive. There are 2 pneumococcal vaccines. Pneumovax 23 is about 60% effective, and Prevnar 13 is around 50% effective. You can also recommend influenza vaccine for high-risk patients. And make sure the patient sees their dentist regularly because the pneumonia pathogens come from the oral cavity. And try to minimize drugs that cause sedation, benzos, opioids. There is some association between PPI use and pneumonia. So if a patient is on a PPI and they have a pneumonia, this simply serves as a reminder to reevaluate the indication for that PPI like we do with C. difficile. So this is a summary of what you should and should not do when managing CAPS. So get a chest x-ray if your suspicion is at least moderate. Follow your local CAP guidelines and use their antibiogram data. What works in one area might not be the right choice in another area. For the sake of simplicity, you can use the abbreviated CURB 65 score to help you decide if the patient needs hospital admission. Try to address any CAP risk factors if present. So in BC, the pneumococcal vaccine is offered free to certain high-risk groups. So you might want to look into that if your patient qualifies for it. And everyone should, be able to get a flu shot by now. Obviously, if the patient smokes or drinks too much, well, I wish you good luck in helping them quit or cut back. So let's focus on what you shouldn't routinely do. So if your pretest probably is low, don't get the chest x-ray. In the outpatient setting, blood, sputum cultures really have little to no impact on management, so don't get them. A follow-up chest x-ray is not routinely required. You might consider doing one if the patient has risk factors for lung cancer, such as age over 50 and a smoker, but delayed for 6 weeks because of radiographic lag. All right. And the last point here is important. Don't routinely change antibiotics in the first 72 hours unless the patient's actually getting worse. Okay, because it can take up to 3 days before you see a clinical response. So on average, it takes about 3 days for fever to subside, 3 to 4 days to reach clinical stability, and 8 days for cough to fully resolve. And sometimes symptoms such as fatigue can take up to several weeks to resolve. And because of radiographic lag, the chest x-ray might not normalize for 1 to 2 months. And so this is why it's difficult to know exactly when the infection is cleared up. So it takes time for the immune system to downregulate itself and for the body to repair the tissue damage caused by infection and inflammation. So just briefly on aspiration pneumonia. So microaspiration of oropharyngeal secretions is normal in healthy people during sleep, and this is the mechanism that leads to pneumonia in the first place. So when we talk about aspiration pneumonia, we refer to macroaspiration of gastric or oral contents into the lung. So this can lead to either a pneumonitis or a bacterial pneumonia. A pneumonitis can present with respiratory distress, hypoxemia, cough, fever, just like pneumonia. But the difference is pneumonitis tends to resolve quickly within 1 to 2 days, while bacterial pneumonia can take a few days to develop and will get progressively worse. So historically, people thought of anaerobes with aspiration pneumonia, but that is mostly true for people who've developed a lung abscess or empyema. So nowadays, anaerobes don't play much of a role in acute aspiration pneumonia. So if you develop aspiration pneumonia in the community, these are the organisms you should worry about. Strep pneumo, Staph aureus, Haemophilus influenza, and Enterobacteriaceae. So a common regimen that's recommended is a Moxiclav for 5 days. So this is a nice algorithm from a review article on aspiration pneumonia. This algorithm assumes you're able to get a chest x-ray immediately, so it may or may not be practical depending on where you're seeing the patient. So if the chest x-ray is clear and the patient is not very sick, then you don't give antibiotics. If the patient is hemodynamically unstable, then go ahead and give antibiotics. If there is an infiltrate or opacity on chest x-ray, then it is reasonable to offer antibiotics. But keep in mind that pure aspiration pneumonitis can also give an abnormal. So if the patient gets better quickly within 1 to 2 days, you can consider stopping treatment sooner because that's how pneumonitis behaves. So let's briefly discuss when you as a primary care provider should refer to a specialist. So these are just a few reasons why you might want to ask for a specialist opinion. The role of the specialist is to help with managing the infection caused by a multi-drug resistant pathogen or atypical organism, such as a fungus or mycobacteria. They can help treat complicated infections like empyema or lung abscess, or they can help with the diagnostic workup to try to figure out why the patient keeps getting pneumonia or why the pneumonia isn't improving. And sometimes a bronchoscopy might be needed for the diagnostic workup, or sometimes we need to think of non-infectious pneumonia-like syndromes, and that's where a respirologist can be of value. All right, so in summary, these are some take-home points for you. So I think we can all do a better job at estimating the probability of pneumonia now that we know what physical exam findings are useful and we understand the limitations of the chest x-ray. Remember that viruses are now becoming the most common cap pathogens, but strep pneumo remains the #1 bacterial cause of pneumonia, especially in places like Europe, where they don't have widespread pneumococcal vaccination and high smoking rates. There is universal agreement that amoxicillin should be first line for low-risk cap. And so now you know which antibiotics and durations are often wrong. So do follow your cap guidelines so that you can choose the best option for your patient. And finally, it's important to counsel your patient that these symptoms can take days to weeks to fully resolve. And there is no point to keep them on the antibiotics longer because this is mostly just reflective of the time it takes for the immune system to downregulate itself and tissue repair. So ongoing symptoms does not necessarily mean ongoing infection. And finally, do address risk factors if they're present. So we've talked quite a bit about those. So like I always say, an ounce of prevention is truly worth a pound of cure. Okay, that's all I got.
Thanks, Davie. That was great. Very practical, nice summary at the end. We have 9 minutes left, so I'm gonna rapid fire the questions to you, if that's okay.
Yeah, sure.
Just a reminder to everyone that if you're interested in the CE credits, you'll get an evaluation email to you. Once you complete the evaluation and email it back to us within a few days, we'll be sending you a CE certificate. And even if you're not interested in the CE credits, we are interested in what you have to say about this particular webinar or anything about the TI or our webinars. Your comments and suggestions are very useful to us. So first question. So someone's pondering about the rational clinical exam and the fact that the chest x-ray does not move the post-test probability up to near 100%. So is the only way to know for sure a culture proven diagnosis?
Yeah, so as we talked about, there's no test that's 100% accurate, and you will never be 100% sure about anything in medicine, no matter how good your test is. So if we take the imaging gold standard as a CT scan, that's what we're comparing sensitivity and specificities to, is that CT scan. Ultimately, if you actually want to know if a patient has pneumonia, you biopsy the lung, look at pathology, look at microbiology, right? So this is one of the reasons why diagnosis of pneumonia is so difficult, is often overdiagnosed as well, is because we don't have good clinical tools on history and physical exam or imaging to increase our confidence a lot, right? So this is the reality, and we're gonna have to accept it, that we are not gonna be good at diagnosing pneumonia.
Okay, moving on to the next question. In terms of penicillin allergy, any options for referral for allergy confirmatory testing in the Lower Mainland? Some people commented about that in terms of the PenFast diagnostic tool for sorting out penicillin allergies, and someone also referred to the penicillin allergy delabeling initiative, one that's occurring at, I guess, BC Women's and Children's. So do you have any comments on penicillin allergy testing and community practice?
I usually do penicillin allergy delabeling in the hospital, and it's easier because they're in a monitored setting. In the outpatient setting, it's usually your community allergist, immunologist who does it. I mean, anyone can actually do this. It doesn't have to be an allergist. If you actually, there are guidelines for it. Fraser Health has a PPO. You can do the history, and if you deem the patient to be low risk of having a true allergy, you can either delabel them based on history, or you actually challenge them yourself. Tell them to pick up amoxicillin, try in your office, make sure you have EpiPen and Benadryl, and you know how to do CPR, right? You can do it yourself. It just takes a bit more time. So I don't know if not everyone's practice or office is equipped to handle these types of challenges. But if you want to do it quick and easy, just do it yourself.
Okay, and maybe we can post the Fraser Health delabeling strategy or other strategies when we post the recording on our website so people can easily access that. Are there any concerns related to inducing resistance, especially in high-risk patients, if only given treatment for 3 days total?
So the resistance question often has a controversial answer, because if you treat too long, you breed resistance. The reality is, you give antibiotics to anyone, you're breeding resistance already. All right, it just depends on how long you're giving it for and how much resistance you're breeding. This is, the the patients in that 3-day trial were high risk. These were inpatients. They had comorbidities. And it was non-inferior to the 8 days. So the concern for under treating with 3 days has not really been proven in these studies. So it's not something that I would worry too much about. In fact, like a lot of the infections we're finding now, when you actually compare short and long durations, almost all the time the short duration is non-inferior with less side effects. So there's, of course, if you're concerned about a complicated cap, then you might want to call for help and go longer. But if it's uncomplicated, even if someone has comorbidities, your 3 days should be your base duration. Maybe call them up, see them again at 3 days, see how they're doing. And if they've met clinical stability criteria by 3 days, you can stop it.
Okay. A related question, are there any resources for patients in terms of stopping early 3 to 5 days, given that this person is saying that the doctors that they locum for are not necessarily going to be able to follow up 3 to 5 days post-diagnosis? So are there any good patient tools out there?
Not that I know of. I mean, I wouldn't be surprised if you just do a Google search and find some pamphlets for CAP. It's so common that you should be able to find something, but I'm not aware of any person.
Okay. So Dr. Wong, curious to hear your practice patterns on chest x-ray for pneumonia resolution. For example, you successfully treated a lady with cefuroxime. She feels better, no symptoms. Worthwhile to snap an x-ray, or do you only grab an x-ray if you had pre-treatment chest x-ray showing consolidation?
So I personally don't. I mean, I see a very different population than family physicians. I see the empyemas, long abscess. I almost always will be doing follow-up imaging, but for the routine uncomplicated cap that resolves with your standard treatment, unless they have risk factors for lung cancer, or you're worried about something else, you're looking for something specifically, then go ahead and do it. But if it's just to make sure it's gone, don't do it.
Okay. And looking at the time, I'm going to ask you one last question. Someone is saying, for someone who has a lingering cough post-cap, is there an inhaler that you prefer to use to help them deal with that, or do you not use prescribed inhalers for that reason?
That's not my typical practice. I mean, we do know that they can have a persistent cough. I don't know if one of the respirologists might be able to answer that question. If inhaled steroids or salbutamol might be helpful, I have no idea.
Okay, great. Well, it is 12:59. Thank you for all your efforts and a wonderful presentation again, extremely practical, and for answering the questions. Thanks to everyone that signed in. We're really glad you participated and look forward to seeing you at a future webinar. And keep an eye on our website. We'll be posting the list of upcoming webinars shortly. Thanks, Davie.
You're welcome. Thank you.